Hello everyone, I've got some MRI scans today, so let's go over them from clinical history all the way through the finished report. I'm going to show you guys every sequence and comment on how to analyze the images. And don't worry, I'm going to try to make it as easy as possible whether you have experience or not. So let's get started. This is a right knee. It's a female patient, 41 years of age. She says her knee is painful. Also, she is going through a breast cancer treatment. So, painful knee, breast cancer. Let's look. This is a 2:2 weighted image with fat saturation. This is a sequence where liquid is bright. This is a T1 sagittal also sequence. This is a black liquid sequence where liquid is dark. This is best for morphology, and this is best for pathology. So I can see there is something wrong with the posterior aspect of the medial tibial plateau. This really isn't good. This looks like a fracture, a incomplete fracture with bone edema, which makes sense because fractures are edematous lesions. Let's see, there is a minor pleural effusion. Also, the fracture kind of extends to the subchondral bone. It can lead to painful knee and a mild effusion. It makes sense. There is always, as always, a tiny inflammation of the proximal extremity of the patellar tendon. Patellar cartilage seems fine. Cartilage is right here. Bone is from the black margin inward. So this is the lateral meniscus. Seems fine. Bow tie appearance is fine. This is the medial meniscus. This tiny right signal here is normal. Anterior cruciate ligament and posterior cruciate ligaments are fine. Periarticular tendons look fine, except for the patellar tendon, which is really commonly affected by a wide range of disease. This is a bursa. This bursa is usually like this. This isn't pathological. There is no edema, nor bone, nor tendinous edema adjacent to it, nor on the infrapatellar fat pad. So this isn't pathological. This is normal. So we are almost done with the exam, and this is just a sagittal view. And we have acquired, of course, other views. This is a really thorough exam on a new and well maintained scanner, because images are great, and they have done a bunch of sequences on a mild case of knee pain. So you can see right here, indeed, there is a acute fracture. This could be even a stress fracture of the knee. This is really common in this site. Really incomplete. There is a cortical fracture right here. Let's get the coronal. See, the cortical bone is ruptured on the medial margin, and the fracture line extends inward and stops before reaching the other side, which makes it an incomplete fracture, which is much more common in cases of stress fractures from bone overload. So the edema, the bright signal on the water weighted images such as PD and T2, like this one, points to us that this is an acute occurrence, this is an acute disease. So just going over the meniscus, fine, triangular shape, acute margin, no exaggerated bright spots, collateral ligaments are fine, cruciate ligaments as well, so very articular soft tissues are okay dokie. So this is quite easy. There is a oblique sequence done to have a great look at the anterior cruciate. As you guys can see, the anterior cruciate ligament is marvelous. So, and there is also a axial view of a liquid weighted image. This is probably a PT or a T2 as well, with fat saturation, because fat isn't white, it is dark gray. As you guys may have noticed, we usually on non-enhanced T1 images make them non-fat saturated, and make them, as we call it, pure images. And every time we do PD or T2 sequences, we also do some kind of fat saturation. So it's always like this: T2 or PD with fat saturation in bright liquid, and T1 as pure as they get. So let's go to the axial view. This is best to see morphology of the femoral trochlea and the patella. Patellar ligaments, retinaculum are fine. The cartilage is fine. It is really just a mild, very tiny, very small articular effusion, and this incomplete fracture on the tibia, on the medial and posterior aspect of the tibia. This is really an easy case, not a common case. This isn't really a common feature. You can also see there is no thickening of the periosteum nor extension excuse me, of the fracture or the possible lesion to soft tissue adjacent to it. So this is a benign disease related probably to a stress, a overload fracture of the tibial plateau. Of course, there isn't a prior history of trauma related to this exam, but we are going to consider it a fracture. So let's go for the report. I'm just going to describe the incomplete fracture and the effusion and the tiny amount of patellar tendonitis. Acute fracture. It reaches the subchondral bone. There is a really small articular effusion. Meniscus and ligaments and tendons are fine, except for the patellar tendon. So let's describe the mild tendinitis of the proximal extremity of the patellar tendon. No signs of tears. Ruptures. Just summarizing the report, as we do with CT scans, we describe profusely as much as we can with coherent language the findings, then we summarize it to make it easy for the referring physician to just read a tiny bit of the report and be satisfied with it. So we make everyone's life a bit easier like this. My life is a bit harder, but I got used to it, and it helps a lot with acceptance of the exams I report. So I have to always summarize the key points, key aspects of the disease I found by reading the exam. So this is probably the most important part of the report is the summary, which goes on the bottommost part of the report. So if you haven't already, this is a great time to hit the like button, hit that like button, and consider subscribing to the channel. Thank you so much. So we have finished our first MRI scan. It's signed, the cache has been cleared, and now we are going to go for a shoulder CT scan. I'm downloading it. It's a female patient. She is 48 years of age, and I'm just copying and pasting my template, of course. Not that dumb. I'm not going to write every single normal finding. I have a template. Let's open it up so you guys can see all that I see. This is a PD with fat saturation, axial view of the shoulder. This is the femoral head, and this is glenoid or the scapular head and the glenoid fossa. So this is the acromioclavicular joint. You can see muscle and skin and subcutaneous tissue all over the place, the tendons and the muscles. This is a coronal view of the same shoulder. This is a right shoulder, and readily I can see there is degenerative disease of the labrum. The glenoid labrum is kind of fuzzy and thickened, so this is painful. Also, I can see the supraspinatus tendon is thickened and has a bunch of heterogeneous areas of high signal, bright signal, hyper intense signal on the PG with fat saturation with no signs of ruptures of tears. So this points us to a chronic tendonitis. There is no sign of bursitis. The subacromial subdeltoid bursa isn't distended nor bright. So this is a chronic disease for sure. A chronic inflamed shoulder. So this is the subscapularis tendon. As you guys can see, there is a bright spot and thickened tendon, and all the way it's heterogeneous. This is chronic tendonitis. On the topmost part, the glenoid labrum is all fuzzy and indistinct. So this is bad. This is chronic articular disease. There could be a mild edema at the site of the bursa. Since this is a PD, the PG may, if there is just mild edema and the PG is made in a really fast acquisition time, sometimes the mild signs of liquid can be blurred out. So we have to check more than one sequence in order to see if mild inflammatory disease is present. Right here you can see this is the approximate site of the subacromial subdeltoid bursa, and indeed there is some kind of mild liquid accumulation or edema on it. So I can say there is a bursitis here, mild bursitis. Also, this is subscapular tendon. Indeed, this is moderate tendinitis. There is moderate tendinitis of the supraspinatus. The infraspinatus looks normal to me, and the teres minor looks normal as well. I don't know, maybe the long head of the biceps tendon, it might be inflamed right here, it might be just a magic angle artifact, but you know, it seems to be some kind of fusiform thickening and signal heterogeneity of that tendon right here. This is a very common site of impingement of that tendon, which justifies the same features of disease, of chronic disease of the other tendon. So this is really common to have the biceps, the supraspinatus, and the subscapular tendon with the same signs of chronic and inflammatory acute disease. So there is also mild arthrosis of the acromioclavicular joint, as you guys can see right here. I guess my face cam probably is on top of this. Now you can see there is bone edema and thickening of the synovial surfaces and the capsula articularis, the articular capsule. And there is, of course, signs of degenerative disease, arthrosis of such a joint. I always tend to say articulation because joint in Portuguese is articulação. So it's kind of hard to not mispronounce that word, since I'm actually, at least in part, thinking in Portuguese and struggling to speak English. So there is arthrosis and some kind of synovitis, which is very, very common on this particular joint, the acromioclavicular joint. So might be some really tiny effusion here. I'm not going to be much positive on that. Also, the infraacromial bursa is slightly distended. Remember, this bursa is in most cases an extension of the joint space. So if the joint is filled with liquid, so is the bursa. Sometimes it isn't. The bursa is distended on its own, and we can call it a bursitis. In this case, I won't call it either way, nor effusion nor bursitis, because it doesn't look like that. Let's see if we can tell if there is hypertrophy of the muscles. Most muscles are eutrophic. They are sized and signal-wise normal. So we have degenerative disease of the labrum, the glenoid labrum, on the most upper and anterior portion of it, which is the most common sign of chronic disease of this joint. In this feature of this joint, we have moderate tendinitis, mild bursitis, and arthrosis with synovitis. So let's go for the report. So feel free to skip ahead to the next exam. I'm just going to be kind of silent now and write this down because there are a bunch of features, and I'm just not, I don't think I can, in this case, write down and speak at the same time. But if you can stick around and learn a bit more. So in the comment, in the description below, there are timestamps. Also on the progress bar, you can click and go to all the other MRI scans I have recorded in this particular video. So as all other videos in this channel. So let's go. It's a arthrosis with mild synovitis of the acromioclavicular joint. Yep, this is it. Yep. Degenerative disease of the glenoid labrum, which is the fibrocartilage that makes stabilizes makes the humeral head stay in place on the scapularis fossa. Yeah, it's a superior and anterior glenoid labrum, or anterior superior. Yeah, now the chronic tendinitis. No tendon tears, at least not that we can see. And there is also a tenosynovitis of the long head of the biceps tendon. So let's just summarize the report and get to the next one. And we are done. Almost. So let's sign it off, clear the cache, and download our next exam. So our next exam is a lumbar spine. Just hit download. It's a lumbar spine of a 19-year-old male patient. Clinical history says let's let it load. The images are already here. It says he has chronic lower back pain. It makes no sense. He is 19 years old, not 90. 19. He is 19. Let's see. I'll grab my template for a normal scan. Yep, normal scan it is, probably. Almost scan, just got kind of messy here because I copy and pasted wrongly. Yeah, it's fixed. So this is a sagittal T2, probably a STIR, a stir sequence, which is liquid weighted with a inverted pulse of inversion recovery, which saturates the signal from the fat tissue and enhances any kind of inflammatory, infectious, or neoplastic disease. Indeed, this is a bad looking lumbar spine. This is a pure T2 weighted image of the spine. The fog The field of view is way too big for this patient. The scanner isn't that good. This looks like a old scanner, probably a low field scanner. Let's get a T1. They have a T1. In T1 scanner, liquid cerebral spinal fluid is black and fat is bright. In T2 liquid weighted images, fat is bright and liquid is bright also, unless of course you do a fat saturation sequence, a inversion recovery pulse to saturate fat. So we also have a very badly done axial image. Yeah, this is a horrible, awful misuse of a MRI scanner, because this image really is that bad. But we can actually make a diagnosis, not as good as we want, but we can actually do. So, as you guys can already see, there is a anomalous joint on the end of the lumbar spine in the transition to the sacrum. So let's see, this is the last rib. If this is the last rib, this is D12. So this is L1. So we have L1, 2, 3, 4, and 5. So this is S1, and S1 is a morphologically transitional vertebra. It's almost a lumbar spine and not so much a sacral spine component. So this is a transitional vertebra, which we will call S1. So let's write it down so we don't forget it. Transitional vertebra. And I will also say it has anomalous joints and a rudimentary disc between S1 and S2, which is the case for transitional vertebrae such as this. Well, since we have established this starting point, we can call every vertebra and every disc whatever we want, because every time someone reads our report, they are going to look for this vertebra and call it as well S1. So this is L5 and L4. So we have two bulging discs forming extrusions. So we have two extruded discs right here, right above the transitional vertebra, which are L4, L5 and L5 S1 extruded discs. They reach the neural foramina and they cause some disturbance on the spinal sac, the dural sac. This is painful as it is. Also, there is probably some kind of bone edema, which is degenerative in nature. Also, we can see there is degenerative disease on the facet joints, but there isn't much stenosis. Just to remember, you guys, this male patient is only 19 years old, so this is major disease for such a young patient. So in L4, L5, as you guys can see, there is indeed a extruded disc right here. This is a normal disc on a sagittal view and on a axial view, and this is a extruded disc, extruded and extruded, a bulging disc. So also here, not so easy to see because of the angulation of the segment and the very bad technique and use of this poor scanner. Poor MRI scanner. You suffer too much, don't you? Come on, man. This is so bad. Let's report it. So this is edema. It is inflammatory bone changes, and there is some, just that. And there is also mild arthrosis, especially on the lower segments of the facet joints of the lumbar spine. So let's go for the rest of the report. Looks very odd, but no. So let's just report the bone edema. It's a modic 1 type of disease. This is L4, L5. And there is diffuse dehydration, chronic dehydration of the disc, especially on the segments. So, especially in L4, L5 and L5S1. Now I'm going to report the extruded discs. White base, enrich the foramina N, bother, compress the dural sac. So, I guess this is it. If you haven't already, please hit that like button and consider subscribing to the channel. This is a great time to do so. Let's summarize the report. Just extrude the discs and a transitional vertebra. And that is it. We have reached the end of this report. We are finished. Let's sign it off and open up another lumbar spine MRI scan. I have already hit download button. This is a even younger patient. This is a 14.5 years old patient, male patient, who says, let's see, it's taking a little bit to load. Let's get the images. They have already been loaded. T1 weighted images. Liquid is black, fat is bright. T2 weighted image. Liquid is bright, fat is bright because there is no fat saturation. And we have in STIR in steer sequence, which is a T2 weighted image with a inversion recovery pulse to saturate the fat everywhere and enhance any signs of acute disease. This looks like an easy one. There is even a coronal plane image, which is nice to look at and kinda useless to report. So it says he has pain on the lumbar spine for a long time. He's 14. Come on. Okay. Someone 14 years old have chronic lumbar pain. Makes no sense. So people are just crazy. I like to go to the doctor to complain about things they have not experienced. So let's go. This is 82 with inversion recovery and fat saturation. STIR sequence. There is no signs of disease. This is a T1. Bones are fine. Muscles are eutrophic. Everything seems to be in place. I can't really see no signs of disease here. Let's get a pure T2 weighted image. Liquid is right. The medulla is right where it should be. The nerve roots are okay. Joints fine. Discs perfectly hydrated and morphologically awesome. Let's go for a axial view. This is the end of the medulla called the conus medullaris, and nerve roots are symmetrical and go to the right places. So there really isn't much to say here. This is a very, very rare, very, very bad done normal exam of the lumbar spine. So let's just save it and go to the next one. Yes, this isn't really something you see every day. So you guys are lucky. I really don't get this every day. So let's go for the next one. The cache has been cleared and we have a cervical spine MRI scan of a 53-year-old female patient. So cervical spine is a bit different from lumbar spine, but we can handle it just fine. We are smart people, we study a lot, we have a lot of experience, and we are going to help each other go through this challenging exam, of course. Let's go. So this is a sagittal view. It's a pure T2. This is a great scanner. Images are just fantastic. So smooth, so devoid of acquired noise, acquisition noise, and bone. It's almost like it's post-processed because it's so smooth it makes no sense. It would be a very, very new, very well maintained scanner. So this is STIR, a STIR sequence. This is T2 fat saturated, almost, kinda. This is to look for edema and enhance signs of disease. This is the base of the skull. This is a transition from the skull to the cervical spine. And we have the discs, the bodies of the vertebra and the posterior elements of the vertebra, and also the muscles of the spine. So this is all here. And also we have an axial view, 82 axial view. That should be something we have to pay attention. Now, there are some cysts on the foramen. These are meningeal cysts. They're pretty common. Bilateral, just accumulation of spinal fluid inside small pouches of meninges that go through the neural foramina, accompanying, following the trajectory of the neural roots, the nerve roots. The nerve roots are also fine, beautiful, and homogeneous, which is great. So we can see here that the discs are kind of dehydrated. This is degenerative disease, very mild degenerative disease, and we can see there is mild, really tiny bulging of these two discs right here, and we are going to give names to the discs based on the position relative to the second vertebra, because this is the first vertebra, the atlas. This is the second vertebra, the C2, which is the axis, and this is the third. So it's 2, 3, 4, and 5. So this is 5, 6, and 6, 7. So we have two bulging discs on the two lowermost segments of the cervical spine, which cause a mild deformity of the anterior margin surface of the dural sac, which is really nothing, and we have this small meningeal cysts up to 0.7 centimeters in diameter on the transitional region from cervical to dorsal spine. This is C7D1 on both sides right here. So this isn't really disease, this is just a peculiar finding. It shouldn't be related to pain. So we can also say that there is mild degenerative signs on the facet joints and on the uncovertebral joints, especially on the segments where there are also bulging discs. So this is the complete picture of a mild chronic painful cervical spine. That is degenerative disease of everything and some mild bulging discs. So let's go for the report. There are also tiny osteophytes on the anterior margins and the lateral margins of the vertebral bodies. So there is reduced height and T2 intensity of the discs, which is translated to chronic dehydration, degenerative dehydration of such discs. Also, there are small protrusions of the discs with mild to known repercussions on the neural structures. Degenerative disease of facet joints and uncovertebral joints. No stenosis. I'm going to add here the cysts. So, cervical spondylosis, protrusions, mild arthrosis and the cysts. And are we done with this? Yes, there is no stenosis, so this is mild disease. And we are done. Let's clear the cache. This particular patient also has gone through a lumbar spine scan. So before we start, don't forget to hit the like button and subscribe to the channel. Thank you so much. Let's get a lumbar spine template because we are smart people. And here it is. It is a great scanner indeed. Great images. This is a much more painful spine for sure. I have already seen at least 2 signs of acute painful disease. What about you guys? Pause the video and leave in the comments below what you have seen so far on this particular patient. Just to remember, you guys, this is a 53-year-old female patient with chronic lumbar pain, lower back pain. So T2, liquid is bright, fat is also bright. This is a STIR steer sequence. This has fat saturation and liquid is bright. So this is liquid weighted, a T2 weighted image. And conus medullaris, where are you? I'm pretty sure, just look for conus medullaris up on the dorsal spine, so it's positioned correctly. This is an axial T2 view, liquid and fat are bright. As you guys can see, when the machine is well calibrated and new, and we don't have much artifacts, the brightness of the liquid is superior to the brightness of the fat tissue. So this is a sign of a great and well calibrated, a new, great, awesome scanner. This scanner is fantastic. Thank God. So we can see here there is mild arthrosis of the facet joints. Also we have hypertrophy and fat infiltration of the perivertebral muscles. We also have small meningeal cysts all over the place in almost all of the neural foramen. So getting back to the case, I'm sorry, my phone rang. I had to get it. So we have here degenerative disease of the discs. This is hypohydration or dehydration of these discs. This is L5S1 and this is L4L5, and we have also here a rupture of the disc annulus, the ring that goes around the nucleus pulposus of the discs. You guys gotta study radiological anatomy, of course. If you want me to do a video on this subject, radiological anatomy of the spine, just leave a comment below and I'll consider doing a video about it. So this is rupture, this is painful. There isn't a actual rupture here, maybe here. Let's see on the axial view. No, can't really tell if there is rupture, tear of the disc annulus. I guess there isn't, but here we can see the tear is right here, the tear, annulus tear right here. So also there is disc protrusion on both of these segments, hypertrophy and fat infiltration of the perivertebral muscles, mild arthrosis of the facet joints, no stenosis, no stenosis. Let me get it. Pure T2. Pure T2 is best to look for morphological disease. Sagittal T2, yeah, the tear is even easier to see on this exam. So, tiny extrusion, just a central focal extrusion right here, and this is a wide base, much larger extrusion right here that reaches the neuroforamina, but that doesn't seem to be any nerve root impingement on this case. It's just tiny meningeal cyst. So this is mild disease, albeit this is painful, of course, but this is mild. Look at this cyst, so beautifully imaged. This scanner is awesome. So great scanner, great scan, mild disease, easy report. So there is tiny osteophytes, So this is the best time to hit that like button and consider subscribing to the channel. Oh, degenerative dehydration of the discs. Principalmente, especially on L4, L5 and L5S1. There is, let's see the yellow ligaments. Yellow ligaments are right here. They aren't thickened, they are normal, so I'm not going to say it, but there is mild arthrosis of the facet joints. Mild arthrosis, I'm going to describe the cysts. Yeah, cysts have been described. Now the hypertrophied perivertebral muscles. This is signs of chronic denervation or just aging of the muscles, especially in cases of people that don't exercise. So muscles that aren't exercised, they tend to age and lose mass and be fat infiltrated. So this is a thing, as you guys may know. So let's just now describe the extrusions, the bulging discs. So there is a tear of the discal annulus, which is painful. There's a concentric tear. Oh. No signs of vertebral stenosis. And a mild extrusion right here on L5S1. There is a mild imprint on the anterior surface of the cervical sac. Yep, let's just summarize the report and get to the next one. I'll summarize the report, makes it much easier to read, so the referring physician is happy with our report much more than if we had not summarized it. So it's good practice. I endorse it and I recommend it. Now it just takes a couple more minutes to summarize the report and it goes a long way. So it is done, sign it off. So we have a XO-T2 or PG with fat saturation, liquid is bright and fat is dark. We can see there is articular effusion and a distended subacromial bursa. There is also heterogeneous and bright subscapular tendon. This is a tendinitis. We have maybe mild degenerative disease of the acromioclavicular joint. Yes, glenoid labrum seems okay on this view. There is mild distension of the sheath of the long head of the biceps tendon. Sheath, I don't know how to pronounce it, I'm sorry. I'm trying my best. Though there is rupture of the anterior and superior glenoid labrum. There is indeed articular effusion on the shoulder. Also there is bursitis right here. You can see the extended bursa right here. The subacromial subclavicular bursa goes all the way from side to side, from front to back of this joint. There is indeed some mild arthrosis of the acromioclavicular joint. I can say there is mild tendinitis of the supraspinatus and probably also the infraspinatus. No fractures. Glenoid and humeral cartilage seem fine except for the ruptured labrum. Labrum is bad, isn't good. So bursitis. There is a longitudinal tear of the biceps tendon right here. See, longitudinal tear. Let's see if we can picture it on the other plane. We should, right here. See, longitudinal tear of the biceps tendon. This is a splitting tear. This is very common. We can also tell on this sagittal acquisition that indeed the subscapularis tendon is bad, supraspinatus tendon is bad, and the tip, the anterior extremity of the infraspinatus tendon is also sick. There is really a bursitis here, a bursitis, subacromial bursitis right here that communicates with the articular joint, of course, as it is most common, and there is a articular effusion, and that biceps tendon tear reaches the anterior and superior portion of the glenoid labrum. So this is a plateful of sickness, of impingement syndrome of the rotator cuff of the shoulder. This is a classic exam. This is a very classic exam. So we have seen all we could see. Let's just go for the report. Tendinitis, bursitis, articular effusion, labrum tear, arthrosis, and all this good stuff right here. So there is no hypertrophy of the muscles. The muscles are fine, so this patient has all he needs to reach a full recovery with proper treatment. So have mild arthrosis of the acromioclavicular joints, mild effusion. I'll call it a mild effusion. It is a mild effusion. So mild effusion of the glenohumeral joint with extension to the subacromial bursa. Subcoracoid bursa. Glenoid labrum tear. We have a sign hyperintensity heterogeneous sign on signal on the supraspinatus and the infraspinatus and the subscapularis tendon. Yep. Teres minor is fine. And we have a thickening in a mid-split tear of the intraarticularis portion of the long head of the biceps tendon. And bursitis and muscles are fine. So let's just summarize this report to make it easier to read. Mild tendinitis, bursitis, articular effusion, and tenosynovitis with a tear of the long head biceps tendon, the tendon of the long head of the biceps. Also bursitis, bursitis is here. Oh, the glenoid labrum tear. So, just to recap, glenoid tear right here, tendinitis right here, bursitis right here. This is also bursitis. Oh, this is on the synovitis of the biceps tendon. This is articular effusion, and this is the ruptured tendon, which can better be seen right here. This is ruptured, this is sick, this is disease, and this is also disease, and this is mild arthrosis of the subacromial, the acromioclavicular joint. So we have done it. It's reported, we won. So let's sign it off. So if you enjoyed this content, I'm pretty sure you're gonna like this video right here. Just click and keep watching. And of course, Thank you so much for watching this video. Don't forget to hit the like button and subscribe to the channel, and of course share this video with people you know enjoys diagnostic radiology. And until next time, I'll see you around.